Good afternoon, everyone, and welcome to Let's Talk About Health, a community conversation brought to you by the University of Maryland Medical System. I'm Donna Jacobs, Senior Vice President here at the system, and I will be your moderator today. Our Let's Talk About Health series began years ago, and it's designed to do just a couple of things: increase awareness about important health topics, provide people with tools to maintain or improve their health status, and of course, to improve conversations between patients and providers. Today's topic is skin cancer, and joining us today to lead our conversation is Dr. Zainab Maksumi, and she's a dermatologic surgeon and Chief of Clinical Services in the Department of Dermatology at the University of Maryland School of Medicine. She specializes in surgical reconstruction, highly specialized advanced techniques for skin cancer, laser surgery, and rejuvenation of aging skin. News to some of us, great news to some of us. Dr. Maksumi received her undergraduate degree and her master's in public health, epidemiology, and biostatistics from George Washington University in Washington, D.C., and her medical degree with high honors here at the University of Maryland School of Medicine. She, following that, received her dermatology training and served as chief resident at the University of Virginia, and then followed that with a fellowship at the University of California, San Francisco in Mohs micrographic surgery and procedural dermatology. These are truly impressive and enviable credentials. This is a virtual conversation, so as we proceed, please feel free to use the Q&A box, not the chat, but the Q&A box to type any questions that you might have, and the doctor will be happy to address as many of those questions as time will allow. We will make her slides available to you after today, and I'll give you more information on that so you don't have to write furiously. And with that, Dr. Maksumi, would you take it?
Thank you so much. Thanks, Donna, for that lovely introduction, and I'm happy to be here and talk about something that is so important as skin cancer, and that really is a growing, truly is a growing problem that we're facing in this country and around the world, and something that is, of course, near and dear to my heart. And so if we can get started, I think, is my PowerPoint? Great.
We can see it.
Great. So what I'm going to be focusing on today are sort of two umbrella types of skin cancer, the two most common. There are a lot of rare types of skin cancer which are beyond the scope of this discussion today. What I'm going to focus on are the two main types of skin cancer. The first is non-melanoma skin cancer, which is comprised of basal cell skin cancer and squamous cell skin cancer, and the other broad category is melanoma. And so what we'll do is we'll just sort of go through each of these in turn and discuss what they look like, how they present, what is the treatment, and what is the prognosis. So non-melanoma skin cancer, as I said, it is a growing problem, and it's one that incidence is on the rise and has been on the rise for the past couple of decades. And there are so many staggering statistics that we could pull and that we could use, and each one I think is more shocking than the next. And so I just sort of tried to pull a couple of what I think are the most sort of jaw-dropping statistics with skin cancer. The first is that there are over 2 million people in the U.S. that develop non-melanoma skin cancer every year, and that is probably somewhat underreported, and that's probably continuing to rise. The other is that there's been a 300% increase in non-melanoma skin cancer since the mid-90s. And one of my favorites is that there are more cases of non-melanoma skin cancer in the U.S. than those combined of breast, prostate, lung, and colorectal units. So you add all of those up, and it still doesn't amount to the number of non-melanoma skin cancer cases that we see in the U.S. And so this is a problem that affects a large percentage of Americans. The more people that you talk to, and as a Mohs surgeon, I hear this all the time, the more people that my patients talk to say, oh yeah, well, I had this procedure done, and oh, I had a basal cell, and oh, I had this done. And so I think that as, it's sort of not just increased awareness, it truly is increased incidence as well. So I'm going to start with basal cell skin cancer because that's the most common form, not just of skin cancer, that's actually the most common form of cancer, period. There are several million cases per year in the US, and that incidence is on the rise. The most common locations for basal cell skin cancer, this is a cancer that's caused directly by ultraviolet radiation, and so it shouldn't come as a big surprise that the most common location for basal cell skin cancer is areas that the sun sort of hits or sees, and so that would be the face, the legs, the arms, but the most common location that we see is the face. So how do we treat basal cell skin cancer? It's you know, there are a lot of different subtypes, a lot of different forms of basal cell skin cancer, which is sort of beyond the scope of what we're talking about today. Basically, depending on where the location is, that kind of dictates the treatment. The first step for any dermatologist when they have a suspicious site is to do a biopsy, where the dermatologist would just numb an area, take a small piece of that tissue, send it to the pathologist. They would look under the microscope and confirm a diagnosis of basal cell carcinoma, at which point typically the treatment of choice would be surgery, which is curative. Surgery in most cases, when we talk about staging, there is no staging for basal cell skin cancer because it's most overwhelmingly locally curative. Metastases, which is distant spread of a cancer to other sites, is exceedingly rare, on the order of several hundredths of a percent, and something that, even in my practice as a Mohs surgeon, as a surgical dermatologist, I think I can count on one hand the number of metastatic basal cells that I've seen. And so, fortunately, metastases are very rare. However, and something that we do typically tell patients is that there is an increased risk once you've had one basal cell. There is an increased risk of them developing more, not of that specific skin cancer coming back in that site, but rather once you develop one basal cell skin cancer, you are unfortunately at increased risk for developing others. And that's why it's important, once you have a diagnosis of a basal cell skin cancer, to really establish yourself with a board-certified dermatologist who can look at your skin either biannually or annually. So treatment options, as I said, depending on the site of the skin cancer, the surgical treatment can be different. For smaller superficial skin cancers, typically on the trunk, so chest and back and arms and legs, we can do what's called an electrodesiccation and curettage, where a dermatologist would numb the area and take what almost looks like an ice cream scooper and just scrape out the skin cancer, and that is giving you a cure rate of about 90%. For more invasive, more aggressive cancers on the chest, back, and extremities, you could do what's called standard excision, where a dermatologist would numb a larger area, remove a larger area of skin, and actually stitch the skin shut. And that could give you a cure rate around the mid-90s. And then for those skin cancers, those basal cell skin cancers that are on high-risk areas, so that would really be the neck up. For those locations, you would want Mohs micrographic surgery, which is what I specialize in. And those are really reserved for areas where tissue preservation is of the utmost importance. So that would be really the face, the neck, the hands, the feet, where the Mohs surgeon acts not only as the cancer surgeon, but the pathologist as well. So we remove areas of tissue and we examine them under the microscope, making sure that the tumor is removed along with all the roots and traces, giving you the highest cure rate of about 99.4%. So this is an example of what you would see for a basal cell skin cancer. A lot of times patients will come in and think it's a pimple, or they'll think it's a little mole that popped up. Sometimes they can develop little blood vessels within them, and that's kind of what I'm showing in this photo. You can see these little squiggly red lines running through this basal cell. This is really common with skin cancers. They're very well vascularized, so they tend to develop lots of little blood vessels within them, and that's what I'm highlighting here. Sometimes basal cells can ulcerate, so when they get to be of a certain size, sometimes the middle actually kind of breaks down and starts to erode, and so that's what I'm showing here. It's just sort of a crusted area, and that's just common with skin cancers in general. Sometimes the centers can get pretty eroded and crusted over. And this is another example of a basal cell. And all of these ones I'm showing you here would qualify for the Mohs micrographic procedure because of the location being on the face. And this is another example I'm showing of the little sort of wavy red lines running through this basal cell. And those are what we call telangiectasias, or very small blood vessels. Sometimes basal cells can be quite broad, quite large, particularly on the trunk, so on the chest and back. And I'm showing here on kind of the back of the left shoulder, a larger basal cell here. And depending on how long they've been there, basal cells, while not being very aggressive, they can grow to a certain breadth or size, particularly when on the chest and back. And the same thing here, I'm showing on the back of the right shoulder, another basal cell. As I said, sometimes when you're on the trunk, basal cells can get a lot bigger than they do on the face. And that's just because a lot of times patients don't realize what they are. And patients say, oh, well, I thought this was eczema, or I thought this was just some dry skin. And so they can tend to persist for a lot longer. Whereas when they're on the face, patients are much more likely to go in and see the dermatologist a lot sooner. This is an example of Mohs micrographic surgery, patient of mine who came in for a basal cell skin cancer on her forehead. I removed the cancer, examined the margins under the microscope. In the middle section photo there, you can see that's the hole the cancer created. And then in the bottom right, you can see this is the patient once I did the reconstruction. So the next most common type of skin cancer, also under the non-melanoma skin cancer umbrella, is squamous cell. Squamous cell carcinoma is more aggressive, so we're fortunate that it is less common. There are about 700,000 cases each year in the U.S. There has been a 200% increase in the incidence since 2001. As I said, squamous cell cancer does tend to be more aggressive. In the year 2012, almost 9,000 individuals died from their squamous cell cancer. So this is a cancer that does carry a good amount of morbidity and mortality with it. It is caused by cumulative exposure to ultraviolet radiation. Similarly, like basal cell, it can occur anywhere, but it's most common on the areas exposed to the sun. There are some special situations where you can develop squamous cells, such as in burns, in scars, and in leg ulcers. Risk factors for squamous cell skin cancer would be light complexion, light colored eyes, having a long time history of sun exposure. There is a two times greater incidence of squamous cell in men than in women, probably not because of genetics, but rather probably just because of the increased ultraviolet exposure on average men get when compared to women. Unfortunately, there is still a good amount of indoor tanning that's going on, even with all the really great work that dermatologists are doing in DC on Capitol Hill, trying to lobby for greater fines and greater taxes and bans on indoor tanning. Unfortunately, believe it or not, some people still do indoor tanning, and there are many cases of squamous cell that are directly attributable to indoor tanning. There also are inherent states that patients have, such as organ transplants, underlying other cancers, and HIV, which can put patients at increased risk for squamous cell skin cancer. Metastases are quite rare, but they do occur. They're certainly not as rare as a basal cell, and they're typically when cancers get to a certain size, or if the patient has a suppressed immune system due to other factors, as I said before. Areas of chronic infection and inflammation can also predispose individuals to developing squamous cell skin cancers. And so people who have chronic burns or ulcers, things like that, probably want to make sure they're seeing a board-certified dermatologist at least once. So the care for squamous cell is really similar to basal cell. It's surgical, and Mohs micrographic surgery is really going to be what we term the gold standard. Squamous cell skin cancers sometimes can look quite similar to basal cells, but usually they'll look a little bit more eroded. So they'll look a little bit more kind of ulcered or crusted, and they tend to be a lot more painful. Patients won't typically complain about a basal cell, but very frequently people will complain about pain or tenderness from squamous cell skin cancer. And that's because, unfortunately, squamous cell cancers tend to invade the nerves a lot more commonly than basal cell as well. And this is another example of a squamous cell skin cancer that I'm showing here, this one on the side of the nose. And this is, highlighting what I'm showing about a lot of squamous cells can get somewhat eroded. They'll bleed, they'll be painful, and that will bring patients into the dermatologist. Malignant melanoma is the most dangerous form of skin cancer. Fortunately, it's the least common, and the cell type of origin for malignant melanoma is in a pigment-producing cell called the melanocyte. Melanocytes are a normal part of everybody's skin genetics, and what they do is their function or their role is to produce pigment, and that gives the skin its color. It protects us from the harmful effects of ultraviolet radiation. When these benign cells called melanocytes develop and become melanoma, unfortunately, it becomes a very aggressive and quite lethal form of skin cancer. Often, these melanomas can resemble normal moles, which is why it's very important for somebody who has a lot of moles or who's concerned about changing moles that they be evaluated by a board-certified dermatologist. Melanomas can present as very dark or unevenly pigmented moles, but they can also present as just pink bumps or sometimes even, unfortunately, clear bumps. The most common location for melanoma on the men is on their back, and on women, it's on the back of their legs. So the basic risk, the main risk factor for malignant melanoma is the intense burst of ultraviolet radiation. So I always tell patients that the main risk factor for squamous cell is cumulative ultraviolet radiation. So it's that little bit of sun exposure that you accumulate over 30, 40, 50 years that tends to cause that squamous cell cancer. Melanoma, rather, in contrast, the risk factor is that brief, intense burst. So you go to the beach, you don't wear sunscreen for 8 hours, and you get a blistering sunburn. It's that brief burst of radiation that's going to put you at increased risk for melanoma. There are about 10,000 deaths in the U.S. annually, although there's probably more than that. And the incidence is on the rise, unfortunately. Melanoma is curative when recognized and treated early, but unfortunately, a lot of melanomas are being diagnosed later and later, and when they're metastatic, even with some very recent advances in immune therapy, unfortunately, prognosis is quite poor. Risk factors, I mentioned blistering sunburns. That's a risk factor. Having a light complexion, light-colored eyes, having blonde or red hair is a risk factor. Having a first-degree relative with melanoma is a risk factor, and there is a certain genetic mutation that has been recently discovered that predisposes individuals to melanoma. So we as dermatologists typically try to educate patients about warning signs for melanoma, and one acronym we use is the ABCD rule. And we sort of try to educate patients about changing and evolving moles. And if they fit these ABCD criteria, we recommend that they see a board-certified dermatologist. And so this is a malignant melanoma that meets all the ABCD criteria. The A stands for asymmetry. Moles, benign moles should be symmetric. And so you kind of bisect them in your mind, and they should be equal on both sides. This one is clearly asymmetric. B stands for border. So when you look at a benign mole, a safe mole, the borders are nice and smooth, they're rounded. You can see here that these borders are very scalloped, they're very jagged. That is a warning sign for melanoma. The C in ABCD stands for color. Moles should be really evenly pigmented, really nice, one shade of brown, one shade of pink. You really shouldn't be seeing lots of different colors. So pinks and reds and browns and blacks, that should be a warning sign. And D is diameter, anything greater than 6 millimeters, which is about, for reference, the size of a pencil eraser. Anything bigger than that, and you would probably want to be seen by a board-certified dermatologist. I'm showing here a melanoma on the lip. Sometimes you can have two different phases of melanoma, where you have a vertical growth phase, which you can see is kind of that black nodule, and then there can be a radial growth phase, and you can see there's like a flat area of red around that as well, and that unfortunately is an aggressive melanoma. There is a specific subtype of melanoma that can occur on the palms and soles, and this specific subtype is called acral melanoma, This tends to be more common in heavily pigmented individuals, and that's just one of the more rare types of melanoma. And same thing here, I'm showing this really meets all of those A, B, C, D criteria. So really you would want to have that evaluated by a board certified dermatologist. And same thing there, you can see that very dark black nodule, it's asymmetric. The border is irregular, it's not even, it's not smooth. So that's another malignant melanoma. I love this slide. I love that. We have templates that we give to patients with the ABCD. I think it's so great. It's such a great way that patients can really, do this on themselves. And I tell people, particularly my skin cancer patients who I see frequently, I tell them once a month to do this and just take inventory. I tell patients all the time, you know your skin better than I do. I am the dermatologist, but you know your skin, you know your moles. And if something fits these criteria and if something's changing, you always want to err on the side of caution and call your dermatologist.
Dr. Maxini, one of the things that we like to do is try to help our patients and our viewers, listeners, speak to their providers. And a tried and true method for patients is to get them 3 questions that they know to ask when they are talking to a provider. And the questions are, what is my problem? And get an answer in plain English. What do I need to do about it? And why is it important for me to do this? So here's a hypothetical to help our listeners. And it goes like this. I had several bad sunburns as a teenager. I have too many moles to count and have had several atypical moles removed. How concerned should I be about developing skin cancer? So what's the problem here? Can you
Yeah. Oh, yeah, there are several risk factors here for melanoma. So I would say, without knowing the age of the patient, which would probably come into play, but this is somebody who's unfortunately had several blistering burns or several bad burns, which is an independent risk factor for melanoma. Too many moles to count. So once you have over 50, that's an increased risk for melanoma, and has already had some atypical moles removed. So this is somebody who, depending on their age, I would probably recommend that they see a board-certified dermatologist at least annually. And if there are some suspicious moles, probably biannually. And I would probably really heavily educate and counsel them about the important, not just the ABCD, but rather being a little bit more proactive and wearing sunscreen, protecting their skin from the sun, even trying to stay inside during those peak intensity hours, between around 10 and 2, taking things a little bit further in order to try to mitigate that already present risk for skin cancer.
Well, that's great. You answered all the questions in that. So what do I need to do? See a board-certified dermatologist at least once a year. Know the signs that you've just gone through, the ABCD. That was really helpful. And then why is it important to identify any problems and forestall any negative consequences? Really helpful. Thank you. Okay, so we have just a few questions. And again, let me just comment. Thank you, first of all, on behalf of everyone who is listening. It was very informative. And while those pictures were hard to see, it was helpful to see them so we have an idea of what we're looking for and what abnormal is, as well as the ABC. It was really, really, really great. You've mentioned several times, and sadly, how much the incidence of skin cancer is increasing across all 3 areas that you spoke about. And so here's a really broad question. What do we do? How do we stem this tide? What do we do?
Yeah, I think that just seeing a board-certified dermatologist for everybody at least once for evaluation is important. I think that we are doing, or we have been doing a great job of that. One thing that I've been seeing, and I'm probably a little bit skewed because my practice is almost entirely skin cancer, but as a result of COVID, a lot of people were sort of delaying those routine skin examinations, those just preventative skin checks. And so we're now seeing a greater incidence, or I'm seeing a lot more cases come my way as a referral, base relying on dermatologists to send their cases. I'm now seeing a lot more skin cancers and a lot more advanced skin cancer, which I really think highlights the need for routine skincare, routine examinations with a board certified dermatologist, at least once, regardless of risk factors, regardless of history of skin cancer, just getting in once and then having that dermatologist tell you, given their clinical training, they can tell you how often you should be seen. But I think that just getting in and getting seen and getting evaluated is the most important thing to do. And then letting the professionals take over from there.
Right. But it also sounds like in part we're seeing them because maybe there's greater awareness and people are coming in, but it also seems like there's an environmental problem that we're confronting, right?
Yeah, I think there's a little bit of increased awareness. Probably it's several things in that people are living a lot longer, which is wonderful. People are getting better care, which is wonderful. Also, people are spending a lot more time outside. All those different lifestyle factors probably play into it. Yeah.
You mentioned melanin a few minutes ago, and I've got two questions here from someone whose name I recognize from many of these sessions. And the first one is, are dark-skinned persons susceptible to skin cancer? And I'd love that. And let's go with the next one. Well, let me do that question first.
Yeah, definitely they are, for sure. And I would say, being a skin cancer surgeon, I do see a fair number of darkly skinned, more heavily pigmented individuals with skin cancer. Now, interestingly, there are certain subtypes of skin cancer that we see more common in skin type 4, 5, and 6. But absolutely you can. I mean, there is a lot of tumor biology, there's a lot of tumor genetics that we don't understand. And so we're not sort of quite sure why certain individuals are more susceptible than others. But yeah, we absolutely do.
And I thank you for that answer, because it really does seem that there's a misperception that if you are African American or Black, that you're not going to get skin cancer, and that is not the case.
That's absolutely not the case. That's absolutely not the case, which is why I say everybody really should get in and get evaluated by a dermatologist, at least one.
Right. So a couple of questions about, what do we do personally? One is, are caps and hats good for sun protection? And then several questions on, and how much sunscreen is good, and what, at what level? Is it 30? Is it 40? Is it 100? What do you recommend?
Caps are not great. I don't love the baseball caps because they don't do a great job protecting the ears and the back of the neck. So I much prefer wide brim hats because they provide protection all the way around. In addition, I really like the wide brim hats with the flap at the back because that really protects the back of the neck. The SPF, in terms of sunscreen and what number to use, I don't want people to get really into the weeds on the numbers. I think once you get above about 45, you're not going to see much of an added benefit. I think it's much more important to be consistently applying and reapplying. If you're going to be at the beach all day, I would way rather you use SPF 45, but apply every few hours and put on SPF 100 in the morning and then nothing else. And then you're like a burnt piece of toast by the afternoon.
Right. So there are some people that once in the sun, they get kind of blistery, it's itchy and blistery, and wear 100% sun protection. Are those people at greater risk, or is that just an allergy to the sun?
There are some allergies to the sun, yeah. There are some rashes, some inflammatory reactions people can get. Those don't cause skin cancer. There's some light eruptions that people can develop with the first burst of exposure to the sun. Those are quite benign, and they don't portend an increased risk for skin cancer, no.
And then I have somewhat related questions. One is, I get these little sort of red cherry-like dots, scalp or on the leg. And then another one related is, and then I get sort of holes in the pigmentation, not raised, they just look white in certain parts of the body, little dots. Mm-hmm. Are those indicative of anything?
No, that's an entity called idiopathic guttate hypomelanosis, which is a really long fancy term for just what you said, light spots. Totally benign incidental finding. The red spots are actually called cherry angiomas. They're small hemangiomas, are clusters of blood vessels in the skin, and they also are benign. More of a cosmetic issue.
Good to know. Someone asked, how long should a thorough skin examination take?
Oh gosh, that's tough.
That's a good question, though.
It's a good question. Yeah, it's a good question. I think it depends. I have, if you're a complex patient with a history of melanoma and 50 atypical moles, it's going to take a lot more time than somebody who has 3 moles and, all the other intervening skin is without finding. And so it really is just going to depend on the level of complexity. And, that's kind of very hard to say a minute, put a minute length on it. I would just make sure that when you see your board certified dermatologist, that they're looking you from, I would say from head to toe. So the top of your head to the bottom of your toes and back up and everything in between.
Do you recommend seeing a board certified dermatologist even if you aren't suspicious? Do you recommend that, just like seeing your PCP once a year, your primary care practitioner?
Yeah, I think PCP is a great place to start. We get a lot of referrals from our wonderful colleagues in primary care. I think if you're established with someone, a dermatologist, then see them. If not, your primary care physician is a great place to start, and they can kind of direct you further.
That's great. That's helpful. Just 2 more questions, I think, that I have right now. One is, my father had a basal cell carcinoma removed several years ago. Does that mean I'm more at risk for developing skin cancer?
No, not only in that, only insofar as you get your skin type or your pigment complexion you get from your parents, and so not in that you're now genetically more likely. No, rather if your dad is fair skinned, likely you are as well. And so, but no, not as we see with a melanoma.
And this last one is something I've wondered, not related to skin cancer, but other cancers. If you've been diagnosed with a skin cancer, does that mean that you're more likely to get another type of cancer, or vice versa?
No.
Not at all related.
Not at all related.
That is great. All right, well, those are the only questions that I see. Oh, wait, there's one more. I have a lot of dark moles and some freckles. Am I at a higher risk for developing skin cancer?
Not necessarily. Yeah.
Okay.
Not necessarily.
Here they come. So one more, and this will be the last one. I've heard sunscreen with Helioplex is the best kind of sunscreen to use. Do you recommend this?
The chemical blockers are fine. I actually prefer the physical blockers, the zinc and titanium. I actually like those better than the chemical blockers. It's just that there's 2 kind of types of sunscreen, chemical and physical. I like the physical blockers because they just kind of sit, and I think they do a little bit better job protecting. So I would prefer the ones with the zinc and titanium.
Dr. Makhzoumi, thank you so much for this advice. And here we are in almost late June with the temperatures hitting at 85 and 90, all wanting and bursting at the seams to get outside after the year we've had. So you've armed us with some really important information. Very grateful. Thank you so much.
My pleasure.
And I mentioned at the beginning that her slides would be available, and they will, at our site. And I do see names that I recognize from other times. At www.ums.org/letstalk. You can see these slides in 48 hours as well. Even now, you can see any of the presentations that we've had over this past year, since starting in last June, and the topics are listed there. And so I thank you, and we will not have sessions in July and August. We will resume in September. And we'll be talking then about fall prevention. And again, it'll be the 3rd Wednesday in the month at noon, as these have been. So thank you, Doctor, and thank you all for joining us today. Have a great day. Bye-bye.